This is Emilio Fentanes with the First Committee interviewing prominent SCCT members, and I have the pleasure to interview Dr. Todd Villines. And Dr. Villines, we have a couple of questions for you. Most importantly, the SCCT, in collaboration with the ACR, has released an expert consensus document regarding the cats rats. We wanted to know, what do you think the impact of this document will be in clinical practice?
Well, as you know, one of the biggest benefits of the cat rats document is that it takes people from across the world and tries to standardize not just how we report, but to take the information in the report and translate that or couple that to how we feel based on literature that these patients should likely be managed. And so I think this is really trying to go beyond just standardized reporting. It's to linking findings on CT that lead to evidence-based changes in therapy. So this is a tremendous achievement. This is a collaborative document, and I encourage all of you to try to read this, and then translate that to how you are reporting your CT reports. Work with your colleagues, and I think this has a real chance to reduce what we call unnecessary variations in care.
Excellent, sir. What are some of the most exciting current randomized clinical trials driving CT-guided care, in your opinion?
Well, I think the term CT-guided care, I mean, taking what is traditionally been talked about, we've talked about accuracy, we've talked about prognostic value, and that's certainly a vital importance to imaging. But to now be able to look at some of the recent trials and to see how CT, meaning your choice of imaging, leads to meaningful changes in management and then outcomes. And so, as you know, recently we've had the PROMISE trial. Much of this is in stable chest pain patients. The PROMISE trial, which looked at a very large number of stable chest pain patients and really documented that a CT-guided strategy was at least as good, if not better, than a functional strategy. And when I say if not better, I think what we saw in that trial was there were similar rates of outcomes, but at 1 year there were significantly lower myocardial infarctions in those who randomized the CT arm. And this may be related to the fact that there was a doubling of the new use of statin medication. So plaque seen on CT, much of it non-obstructed, was leading to changes in how prescribers and patients behave. And this, the other notable finding from PROMISE was that we saw a significant improvement in the what we call the false negative, or I should say, a significant reduction in normal angiography. And so a significant portion of patients, more than half, who got cath in the functional arm had no significant disease, but that was really uncommon in the CT-guided strategy. So hopefully we're getting the right patients who are most likely to benefit to the cath lab. And I think a complementary trial to that was the Scott Hart trial. That again was a very large study of over 4,000 patients that was done in Scotland, and it compared CT versus usual care in symptomatic patients with stable disease who had exercise treadmill testing. And it showed again very much similar to what we saw in PROMISE, was that patients who had CTs were treated differently. So all of that non-obstructive disease that you saw led to significant increases in statin use, aspirin use, and in fact in the CT arm, what we saw was a 50% reduction in MI rates in Scott Hart. So now, being able to extrapolate not just an accurate test, but in a highly prognostic test, but to be able to move the needle to changing how patients are managed, and in fact, changing how well they do. And so that's been, I think, a very exciting advance. And I think lastly, there's some really exciting new technology. So can we use things like CT FFR to improve the specificity in those patients that have indeterminate lesions? And I think the platform trial showed that if you were going to the cath lab, that a CT FFR could keep the majority of those patients out of the cath lab, do it in a safe manner, and significantly reduce what would be considered unnecessary catheterizations and lead to lower costs, in fact, and improvements in quality of life. And so these are real exciting clinical trials now. We've known for years that the emergency department, the acute chest pain, has had now 4 large randomized clinical trials. In fact, actually, I should say 5 randomized clinical trials that have consistently shown that you can reduce costs, at least length of stay. And now we're starting to see some outcomes data from this as well with the CATCH trial. So that patients have lower rates of MACE at between 1 and 2 years. So, and that has led to new guidelines, and now a recent 2015 appropriate use criteria
Right.
document for the use of CT in the emergency department, where CT is in fact the most appropriate test in patients without known coronary disease who come in with low to intermediate risk acute chest pain.
Excellent, sir. All of this information, what are some of the early practice, early career opportunities available in cardiovascular CT?
Well, I mean, you're standing. This is a great example. So the SCCT first, the fellows and residents in training, that committee has been tremendously active. It's been a tremendous addition to the society. The first committee has been involved in writing training documents. They've been involved in revising board review material and documents in that area. They have been involved in developing new platforms for learning, which I think you're going to see as part of the new SCCT learning management system, and where folks can actually go online and access all the wonderful content from this meeting. And in fact, do things like interactive case reviews through what's called RAD-IQ. So I think if you're involved in cardiac imaging, I would advise all fellows and residents to join the SCCT. We're looking at getting this year for the first time sponsored memberships, so we may be able to sponsor up to 400 members for free. They'll get access to all of the content of this meeting. They'll have access to interact with people in the field, network, and so I think probably the best place is the SCCT first committee.
Excellent. Well, thank you very much for all of your time, and we appreciate all of your input, and I hope you have a great meeting.
Thank you.